Good afternoon, everyone, and welcome to this webinar on Steady Steps Forward Systems Thinking Approach to Falls Prevention. My name's Rachel Mead. I'm General Manager of Injury Prevention here at Injury Matters and a member of the Australasian Injury Prevention Network. Before we get started, if you're not registered for the webinar individually, if you've joined through a forwarded link, that's okay, but you won't be able to use the chat and Q&A functions of the webinar. So if you do want to take a moment, if you've been forwarded the link, to jump out and register through the Injury Matters website to make sure you get those functions. There's a moment to do that now, and that way we make sure you can participate in the conversation moving forward. I'd like to thank everyone for joining us today and taking time out of your day to discuss this important topic of falls prevention. Today I'm hosting this webinar from Whadjuk Noongar country, and so I'd like to acknowledge the Whadjuk Noongar people as the traditional custodians of the land where I am here in Western Australia, and pay my respects to their elders past, present and emerging, as well as any Aboriginal and Torres Strait Islander people who are joining us on the webinar, and we're from wherever you're joining from today. Australia always was and always will be Aboriginal land. So before we get started, a couple of quick housekeeping points. You'll notice that your microphones and videos are turned off during the webinar. We would like to hear your questions, and there will be time for a robust conversation, hopefully at the end with our guest presenters. So throughout the presentation, feel free to use the Q&A box and we will go through those questions at the end to guide our discussion. If you do have more than one person joining you from wherever you are logging in from today, we would appreciate if you could send us a quick private message via the chat tab to let us know how many people are joining you and listening in today. And if you face any technical issues during the presentation, please let us know through the chat function and we will do our best to help you. We have the lovely Apu who's in the back end looking after all the technical aspects today. And I will take a moment also to let you know that today's webinar is being recorded. So a little bit about Injury Matters. We're a not-for-profit organisation based here in Western Australia, and we innovate and deliver injury prevention and recovery solutions. Solutions that keep people safer and healthier at home, at work and on the go, and solutions that save lives and make our community stronger. Our approach is as expansive and inclusive as our remit, which spans everything from road safety to trauma recovery, of course, falls prevention, which we're well known for, as well as through to substance-related harm. As a not-for-profit organisation, we work with local government, industry, government, health, emergency and social service partners, and we draw on the latest research and evidence, as well as lived experience here in Western Australia, to raise awareness of injury risks, consequences and solutions, to prevent injuries through a range of education and support programs, to support recovery of people, families and communities impacted by injury and trauma, and to advise and enable local and national agencies and policymakers to make smarter, safer, more informed policy decisions to support those needed to support the needs of the community we work with. And I think that's really relevant to the topic that we're going to be talking about today. So together at Injury Matters, we find and share injury prevention and recovery policy solutions that keep everyone safer and healthier, solutions that reduce the far-reaching physical, emotional and financial impacts caused by injuries and trauma. Our program, which we are most well known for and that we've been delivering for over 23 years today, is the Stay on Your Feet program. And that is a program that is bringing you today's webinar with the support of the WA Department of Health. So the Stay on Your Feet program provides information, training and support to older community members and professionals working with older adults on how to prevent falls in the community. And we do this through our Move, Improve, Remove campaigns, encouraging people to move their body, improve their health and remove hazards to prevent falls and maintain independence. Injury Matters is pleased to be able to offer this webinar in collaboration with the Australasian Injury Prevention Network. The AIPN is the peak body for injury prevention in Australia and New Zealand, and they're an independent non-government network representing all age and all cause injury prevention and safety promotion in the Australasia region. Our members are made up of a variety of different practitioners, researchers, allied health professionals, and industry and NGOs as well, all working in injury prevention and safety promotion. We have a really broad membership, so if you're not already a member of the AIPN, I would strongly encourage you to get involved to see how you can contribute towards collaborative efforts to improve health and safety and wellbeing across Australia and New Zealand. So today, of course, we're here to talk about falls prevention among older adults living in the community. So falls in Australia are the leading cause of injury, hospitalisation and death in Australia, with falls contributing to 43% of injury hospitalisations and 42% of injury deaths. The story is consistent at a local level for us here in Western Australia, with falls continuing to be that leading cause of hospitalisation in WA. The 23 falls report, which was published by Injury Matters, highlights that in Western Australia, someone dies every 19 hours, is hospitalised every 15 minutes and presents to the ED every 11 minutes due to a falls-related incident. And I guess I just wanted to mention there's a lot of data available within the falls report. So if you really want to delve into who is impacted by falls in Western Australia, this is a great source to go to. I guess what I really wanted to touch on is that falls is a significant public health issue in Western Australia, nationally and globally. Despite this, though, there remains no national injury prevention strategy in Australia, and more specifically, no national falls prevention strategy. Systems thinking is an important approach to health policy and prevention. However, it's not really been applied to the challenge of preventing falls among older adults. So it is a pleasure for me today to introduce our three guest speakers who will be presenting their research into a systems approach to falls in older people in Australia. So our main presenter for today is Dr. Nathalia Costa. Nathalia is a Senior Research Fellow at the University of Queensland's Clinical Trials Capability Team. She is also an Adjunct Research Fellow at the Menzies Centre for Health Policy and Economics at the University of Sydney, and she has an enormous amount of publications that address musculoskeletal health policy and sociology. And most recently, her research has focused on qualitative methods and methodologies to make meaningful contributions to randomised control trials with a view of making them better aligned to real-life context. Joining Nathalia, I believe, hopefully, to guide the conversation and answer some questions at the end will also be Professor Kim Delbaere. Kim is a Senior Principal Research Scientist at NEURA and Director of the Innovation and Translation at the Falls, Balance and Injury Research Centre, supported by the NH and MRC. And finally, also joining Kim and Nathalia is Dr. Meghan Ambrens. Meghan is a postdoctoral fellow at the Falls Balance and Injury Research Centre at Neuroscience Research Australia in Sydney, and Dr. Adrians is also Associate Lecturer at the University of New South Wales. So without further ado, I will hand over to you, Nathalia.
Thank you. Thank you for the lovely introduction, Rachel. I think, yeah, this just stopped sharing. I should be able to share my slides with you. Can you confirm that you can see
Perfect. Yeah.
the slides on a full screen?
Yes.
Great, fantastic. Thank you. Thank you very much for the invitation to have a conversation with you today about our study, which, as you mentioned, we really try to apply a system lens and use a systems approach to reflect about how we could aid policy action in this space of falls prevention, particularly among community-dwelling older adults here in Australia. I'm presenting on behalf of my great and stellar team. So thanks, Meghan, for joining today. Kim should be here sometime soon. And throughout this presentation, I would like to invite you as the audience to reflect with me about the issue, about some of the challenges that we face within this context in Australia, and try to really not limit yourselves to what I'm presenting. My understanding is that this audience is an audience with a lot of clinical experience, a lot of experience working with the community, developing models of care, campaigns like the Move, Improve, Remove one. So please don't limit yourselves to what I'm presenting. Try to put your systems thinking hat and think about solutions and goals and potential challenges and how to tackle them to move this field forward. So throughout this session, I'll be asking you a few questions, and feel free to take notes as we go, because that might help us with our discussion later. So if you're here, you're very familiar with the burden of falls. So Rachel already highlighted some really alarming stats, and we know that at the individual level, falls can cause injuries. It can make particularly older people lose their confidence. It can lead to frustration and other negative emotions. It can lead them to become more dependent on family members and other carers. They end up very often reducing their participation in valued activities. So it might even be intertwined at times with social isolation and reduced quality of life. And in the worst case scenarios, it can actually lead to death. And we know that older Australians are 68 times more likely to die due to a fall than people who are aged between 15 and 64 years. And at a healthcare systems level is actually a leading cause of injury-related deaths. And again, once again, older people account for 94% of all fall-related deaths. And it costs our healthcare system something around $2.3 billion each year. And I could spend the whole 40 minutes here talking about some of the alarming stats. So we know that there is a visit to emergency departments by older people every 2 minutes and 30 seconds because of falls. We also know that every day, approximately 14 people will die from a fall. And I took this from your website. And again, you cover some of those stats, but it becomes to me very clear if we look at the top right of this slide that there are some disparities depending on where you're located. So within your state of Western Australia, the rate of falls is higher in areas that are rural and remote, like the Kimberley. So there are some inequities that need to be addressed, and the problem is actually quite big. However, there hasn't been really an adequate policy response and frameworks that really consider the multifaceted nature of the problem we are dealing with. And this is consistent with the argument from the World Health Organization. So this data is actually very similar all across the world. There is a lack of policy action in this space. And also, this is an argument that has been put forward by Nathalia and colleagues. So they reviewed policy documents that target falls specifically, and a lot of them, for instance, were outdated. So that's where the systems thinking approach comes in, because in order to understand, for instance, why there has been policy inaction in this space, we need to understand the relationships, the boundaries, and the perspectives that might be underpinning this scenario. So when we draw from a systems thinking perspective, rather than looking at things in a disconnected way, in isolation, we really look at how several factors might come together to create this whole of relationships that might be very much part of the problem, and they might perpetuate the problem. So really using a systems approach is to make sense of a complex issue through problem solving by exploring these different parts, these different boundaries, and these different relationships within a system. So within the space of chronic disease prevention and public health more generally, it's moving beyond just simply targeting individual behavior and really looking at the many factors that may impact individual behavior, including the conditions in which we work, we eat, the kind of diets we eat, how we play, how we live, and how we may or may not have access to education and healthcare. So it's really looking at the problem from a broader perspective, and it comes from this premise that it's not enough to simply urge Australians to eat better and exercise more. We need to really look at the wider systems that directly impact our health and our power of choice. And to do so, we need to look in depth at the communities we serve, our food systems, the environment, our workplaces, and how all these factors interact to shape problems like falls. And an essential aspect of applying systems thinking is to actually dig into the policy landscape. So trying to understand the policy landscape by looking at, yes, the number of policies that may have been developed, the content of these problems, the content of these policies, as well as how the problem is being framed in these policy documents, and also how the solutions proposed to tackle some of the challenges embedded in the policy issue. So we do that by identifying gaps, and it has been argued that by doing so, that can generate a lot of learning, so policy action through policy learning. And this would allow us to adapt and gain insights from several perspectives and hopefully get to a point where we understand the necessary conditions for policy change and policy success. So it's very much a reflective activity. And in our work, we used the first component of the prevention systems change framework. So I took this from a presentation from Dr. Melly Piscard, who is the first author on the paper in which this framework is described. And the framework itself has 4 elements, as you can see there. The first one is to apply a system lens. And this is what we did in this first step of our work. And then drawing from that, the authors argue for taking an implementation focus and then integrating this system lens from the first step with the second step of implementation. And after that, developing a theory of system change and really getting quite deep and granular in terms of how the change might happen. So to really truly go through the whole process of applying the framework, we would need a lot more time than what we had at the time. And that's why we focus on the first step. But there is more work that we are planning to do moving forward to address some of these other aspects. And if anyone is interested in joining forces and joining us, just let us know. But essentially, the framework prompts prevention researchers to move beyond describing the systems and really advocating for action-oriented research. So through specific questions, they guide us through this reflective learning process according to these 4 main themes, main domains. And as I said, in this work, we focus on the first one. So our aim here in this work was to really try to understand the current landscape of policies targeting fall prevention in Australia and potentially identify some pathways for change, drawing from our findings. And to do so, we attempted to answer to these questions. So we were very interested in understanding what content the documents cover, documents that we identified. We were also interested in understanding the gaps in the current policy landscape and how we could potentially address some of these gaps and improve false prevention. And this is part of a broader advocacy work that is being led by Professor Kim Delbaere, who will be here at some point. She's busy in another presentation, but she'll jump in to talk to us. Maybe she's there already. And also Professor Kathy Sheraton, who is based at the University of Sydney, also couldn't be here with us today, also presenting in New Zealand, actually. But just to situate you, and Kim and Meghan will further elaborate on that later. So this is part of a broader advocacy theme that they are leading. In terms of how we did it, the methods used, I won't bore you too much with the different steps, but in a nutshell, we conducted a desktop search in 2022. We updated this desktop search in 2023. And then we also asked the people who were involved in our team to let us know about potential policy documents that they knew about. And then we reviewed all these documents that were identified according to these eligibility criteria. So each of the documents was screened by 2 reviewers. So we looked at documents that were publicly available. They had to reference false within the context of older adults. They had to fit with our definition of policy by Booz and colleagues, which is essentially a broad statement of goals, objectives, and means to create a framework for activity, for change. And they had to also be produced or endorsed by the federal or state government authorities. And then once we screened these documents, Meghan and I, we looked at the content of these documents. We summarized the content, we shared this with the team, and then after that, we met to have some collaborative discussions with the whole team about the content while being guided by some of the questions from the framework I mentioned earlier. And because this is it was a reflexive activity, I think it's very important that this is not us, by the way, but I thought that there was a nice photo of a team working together in collaboration there. You should actually have taken a photo at the time. We didn't. But it's important that we are explicit about our collective positionalities. So we draw from different lenses, from different disciplines, different research backgrounds. So most of us have some exposure to false prevention research. Most of us had experience with public health. I for instance, had a postdoc in health policy. One of the other co-authors had a strong background in urban planning, aged care, health economics, housing, health inequities. We were all very interested in this topic, and also all interested in advocacy for policy change. So I'm just being explicit about this because, of course, that very much influenced how we looked at these documents. And these are some of the questions that guided our discussions, our meetings. So we recorded these meetings while being guided by these questions. We had discussions about them. And then I summarized the meeting notes, so the analytical summaries of these meetings, presented them back to the team who provided further input to the meeting notes. And we co-constructed the results through this back and forth process. And in terms of the results, we identified 47 documents that we assessed for eligibility, and we included 8. So the analysis that I'll be talking about now draws from the 8 documents, and there is a list of these 8 documents in the manuscript if you're interested in knowing exactly which documents we looked at. And then in terms of the content, they described falls very much as you would expect, looking at the epidemiological data on falls. Some of them also describe the risk factors for falls, such as physical inactivity, poor nutrition, and chronic diseases. One of them identified a gap in terms of the lack of cost effectiveness of balanced programs in rural and remote areas. And another one talked about a gap in service provision and really exposed that there is limited assessment and intervention for falls in Australia. In terms of the goals, they often talked about preventing falls prevention, and at times this was very much intertwined with the idea of decreasing fall-related insecurities. So the number of people who may not leave the house, for instance, because they're scared of falling. Some of them also talked about the goal of having one online directory with community-based physical activity and fall prevention programs. Another one talked about delivering a free prevention program in order to prevent falls in the community. But on a side note, it's interesting because this specific program was limited. They could only deliver the program to about 2,500 individuals, and that was in New South Wales. And we have close to 2 million people who could be considered older adults in New South Wales. So that just goes to show how the number of people who could potentially have access to the program doesn't quite match the number of spots that are required to really address the problem from a broader community perspective. Some of them also talked about expanding these falls prevention programs to regional areas, establishing education programs targeting falls, expanding emergency department services that target falls, and also working with stakeholders to develop a strategic plan for falls. So I'm aware that Injury Matters already addresses some of these goals in the work you do. So I invite you now, and again, feel free to take notes. We can discuss these things later. But I invite you to think about other goals that you think that might be important to address when it comes to falls prevention. So once again, don't limit yourself to what I'm presenting here. You have a lot of experience, and we would love to learn more about your experiences and perspectives. They also discuss a lot of this idea of collaboration. So it was often stated that the documents were developed in a collaborative way. Only one document didn't mention that explicitly. However, it was very rare that these documents would actually provide detailed information about how they identified the priorities with stakeholders, or even described how the consultation process, how the collaboration actually took place. And only roughly less than a third of these documents emphasize the importance of collaboration across sectors. They also had some actions that were highlighted in terms of targeting falls. For instance, improving home environment, increasing access to falls prevention programs, including programs that target people from multicultural backgrounds, or even developing programs that might be relevant for Aboriginal and Torres Strait Islander peoples. They also talked about including design features to reduce falls in public buildings and paths, and developing both guidelines and models of care to prevent falls in health services. And once again, I invite you to think with me and reflect with me and consider whether there are any other actions that you think that might be important in this space, drawing once again from your collective experiences. We'd love to hear more about that. In terms of monitoring and reporting, only half of these documents is specified the indicators that could be considered, meaning what could be measured in an attempt to monitor whether action is actually being addressed and having the expected outcomes. And I guess that comes with several challenges, because there are resources that are needed to monitor and report some of those things, and a lot of resources in terms of both human power and financial resources to, for instance, conduct process evaluations of various programs. But once again, I invite you to think with me and consider whether there are any other indicators that could be important when monitoring and reporting whether we are progressing in this area. So a lot of the times, the indicators were rate of falls, years lost due to falls, number of hospitals with pathways that address falls specifically, a number of people leaving the community who have the confidence to participate in activities without feeling fearful about falling again. So again, if there is anything that you think that might be missing from this, write it down. We'd love to hear more your thoughts at the discussion when we have time to discuss. They also talked about the importance of involving key stakeholders, and there was a very varied perspective in terms of the nature of these stakeholders. So some of them mentioned stakeholders at a very individual level, so clinicians and families, and very rarely, but there were a few documents that actually talked about cross-sectoral action, so including academics, government, not-for-profit, non-government organizations, communities, and the business sector, including private health insurers, for instance. When we were thinking through the questions that were posed by the framework, for instance, whether there were any gaps about the policy landscape and what additional policies could benefit the context, the scenario, we identified that there is a need for a comprehensive national policy that is dedicated to falls prevention and acknowledges that is a problem. It is a public health problem, and it is a problem that is multifaceted by nature. So, for instance, the Injury Matters came up with the lovely campaign, Move, Improve, Remove, but public health campaigns was something that wasn't necessarily covered in these documents. So there is certainly a need there for a broader national strategy. And when we thought about the different domains that could, and again, we did that by drawing from our multiple backgrounds, but also thinking about some of the content of these documents, there wasn't a document that covered all these systemic aspects, things like the social determinants, the individual determinants. So some of them addressed some of these things, but there wasn't a comprehensive plan that actually touched on all these factors that may indeed impact the scenario of false prevention. When we thought about the gaps, we also identified a need for having some clarity regarding how the strategies could be implemented, monitored, and evaluated, and the governance structures that would need to be in place in terms of who would do what and when. We also identified a need for clarity regarding the agencies and partners. So they were often mentioned, but once again, the involvement in developing those documents and implementing these strategies to achieve the desired goals was more often than not very unclear. And the collaborations were mentioned, but again, there wasn't a clear plan that defined the role of each actor in enacting some of these policy recommendations and goals. So a lot of the times, who would do what and when was unclear. In terms of the domain of connections and boundaries, another domain that is covered by the framework we used, we identified that there is a need to really involve those who are potentially more likely to experience inequities, including Aboriginal and Torres Strait Islander peoples, people with disabilities, those who live in rural, remote, and regional areas, people from multicultural backgrounds. So we know there are inequities in service provision across the whole spectrum, but it's important to really try to involve these stakeholders in order to reduce some of these inequities. We also identified a need to involve actors such as the private health insurers to identify interdependencies, because they can gain a lot from this problem being addressed. And by identifying these synergies, these potentials for mutual benefit, we could then define the involvement and targets for intersectorial action. And then we also identified a need for a single repository, and that was one of the things that was mentioned in one of the documents, to really help data sharing across different government levels, across different stakeholders. So for instance, when we think about the national survey, there is no data, there are no questions that are being asked at the moment that a specific target falls. In terms of power and control dynamics, that is a bit of a tricky one, but when we were having our discussions, we thought that maybe there could be a potential for a leadership, a task force for coordinated action. So there could be an institution, a group of people who could be responsible for communicating and coordinating action across a range of stakeholders. And we thought that maybe the Department of Health and Aged Care could be that institution, because they have an overarching national responsibility for false prevention. But again, would welcome your thoughts on that. In terms of system regulations, we reflected on policies and procedures that could be needed to support the overarching goal of tackling this issue, and also how the current scenario actually motivates intersectorial action to create these changes. And when we were reflecting about these things, we thought about the need to come up with tailored programs for middle-aged and older-aged people. We also reflected on the importance of establishing interdisciplinary partnerships and recognizing falls as a multifactorial problem that often overlaps with other health conditions. And as I said earlier, there is potential there for developing inclusive mass media campaigns. I really like the one you came up with, and it made me think whether this could be rolled out at a national level. We also discussed the importance of having financial incentives to promote engagement in activities that align with false prevention. So again, private health insurers could potentially help to navigate that. And also considering a lot of scope to really truly consider false prevention as something that needs to be tackled from a public health perspective, because the fact that none of these included documents focus solely on false prevention is telling us, in and of itself, is telling us a lot. So it seems that FAW is not really perceived as a public health challenge that requires a solid action plan on its own. And when we reflected about values and norms, we also reflected on potential attitudes that could obscure some of those changes and challenges. And ageism seems to be a big one in Australia. So most Australians actually believe that it exists in Australia. And when we look at data from older adults, 64% of them reported that they have been stigmatized because of their age in the last 5 years. So again, I think these are very alarming stats. And if we think broadly, from a system perspective, these values and norms, societal norms and values, are very much part of the problem we need to tackle. We also discussed the role of ableism, the stigma, and how falls is often framed as an event. So it's neither a chronic disease nor an injury. It's kind of sitting in between. And maybe this is also part of the problem, how it's intertwined with all these things, but it's not really neither an injury itself, because it's an event, and some could argue that it couldn't be considered a chronic issue either. So that in and of itself can be quite challenging. And last but not least, when we thought about systems in the interdependencies, we try to really think deeply about potential key leverage points for addressing this issue. And once again, I invite you to think with me and expand some of the thinking that we initiated. So we thought about the importance of establishing a task force based on what we identified in these policy documents, the need to integrate falls prevention goals and strategies across sectors such as urban planning, transport, and housing policies. One of the documents highlighted the importance of having a local, a single source of information. So perhaps there is some potential there to build a centralized repository with all the local and state-based fall prevention initiatives, such as some of the ones you initiated through Injury Matters. We also thought about how to promote these courses and actions that purposefully try to address some of these health inequity challenges and the stigma that comes with ageism and ableist discourses. We thought that there could be a lot of space to promote physical activity opportunities within the community. We know that this is very key when it comes to preventing falls, allocating more funding for non-pharmacological interventions. So there is a lot of important roles that allied healthcare professionals could play in this space. And maybe that ties in with the broader need of having a reform in our healthcare system and potentially changing how Medicare works. And also thinking about how to build capacity within the health sector and aged care sectors, just so they can have some discussions about how to prevent falls And I'm sure a lot of clinicians will do that already, but just based on what I understand, it is not done consistently. There are some challenges that come with that. And maybe this is something that could also be optimized through capacity building. So to summarize, there was a lot of mismatch between the extent of the problem and those alarming stats that we discussed at the start, and the attention that has been given to falls prevention. And we argued that we really need a systemic and a collaborative approach to falls prevention that really leverage the strengths and the insights from various sectors, from various stakeholders, to pave the way for more effective, sustainable, and equitable approaches when it comes to falls prevention. So thank you very much for listening to me, and I will now excuse me, hand over to Kim or Megan.
Yeah, I'm here. Sorry, I heard most of your talk, Nathalia, but I was stuck in another meeting. But thank you so much for this wonderful overview of the work that we did in relation to this paper. And thank you, Rachel, as well, for inviting us to speak. It's a great opportunity. Can you just, how long would you like me to talk? How are we going for timing?
We've got plenty of time, but
okay.
7 to 10 minutes, is that enough time for you?
Perfect. Yes. Just wanted to make sure that I didn't accidentally go over time because I missed the start of the meeting.
No problem.
So great. I will now just struggle with using Teams because we don't often use Teams.
Kim, if you go to the top right, I always struggle with it as well. Just go to the top right, share.
Yeah.
If you click on it, there will be screen and windows. So you just click on window, and then it should give you the different options of windows you have open in your computer.
Oh, okay. No, that's not working. I need to give permission to start sharing.
Oh, you don't have permission?
No, I don't either.
I wonder if it is actually in my computer. How about if I just send you my slides?
Yeah.
Yeah. And then you can share while I will just then briefly just talk before we start that process. Just give me a second because dual tasking is not my strength.
Just maybe while Kim is getting that together, I might comment on a couple of observations, if that's okay, Nathalia. From your research, I guess the things that really stood out to me, well, I guess first of all, congratulations on publishing this important work, but really the contribution of ageism towards health policy, and I guess it shocks me that falls can be the leading cause of injury, hospitalisation and death in Australia across states, and yet we don't have strategy to focus on that. So I guess that was like my first observation. I guess the other thing, it really reinforced, I guess, our experience delivering falls prevention campaigns when you talked about the I guess for us, the challenge of targeting multiple generations with, I guess, limited resources, I think is fair to say. So we're trying to talk to people in their 50s, 70s that think that we're talking to their parents, or, you know, they think this is great for mum or dad, as well as people that are in their 90s as well. So, and those people are all motivated by different things. They have different motivators for behaviour change. So, yeah, just the different generations we're trying to tackle in terms of this challenge really makes it difficult. And the other thing I guess I wanted to comment on as well, when you talked about the importance of integration across sectors. So you touched on different government sectors in terms of housing, health, those sorts of things. I would bring into that realm also the financial and tax systems of Australia. So by that I mean within Australia there is the ACNC, the Australian Charities and Not-for-Profits Commission, who oversee the charity status of Australian NGOs. Now, within that, there is a group, a classification of health promotion charities. So those charities can get deductible gift recipient status. Injury does not meet the classification of a health promotion charity. So it falls. So us as an agency who work in the realm of falls prevention, we can't be classified as a health promotion charity because of that exclusion criteria. And that means that we can't tap into the resources that those other, it was interesting when you were talking about chronic disease, that those other chronic disease topic NGOs can, which means we're reliant on government grants to do our important work. It means that we can't get philanthropic donations. It makes it harder for us to attract and retain a skilled workforce. So it's not just that there's ongoing systematic impacts. So with that said, I'm not
Thank
sure.
you for that. I knew that we were going to learn from you and from your experiences. I am shocked by this. It's certainly something that I wish we knew earlier so we could talk about it in a paper.
I mean, there's always lots we can learn. Has someone received the presentation, the slides?
Yeah, I haven't received it.
No.
Oh, sorry. They've just come through to me. Yes, perfect.
Okay.
I actually want to say something about that just while you're getting that going up. I think I'm actually not, it's a shock, but it's also not surprising to me. So this work was undertaken out of the Centre for Research Excellence in falls injury prevention. So that research group and that sits within the prevention centre. And so there are actually a whole number of, like a lot now, of Centre for Research Excellence. And when I interact with other early to mid-career researchers across the different groups of research focus, it's hard for them to understand how falls fits there, right? And so if like that is, I think that there's a whole lot of education that needs to happen across different segments of society about, and it starts with the statistics. Like, guys, actually this is a problem, and it's a problem of this magnitude, and it will have this impact, and it's a preventable problem. And and it's just trying, and that understanding actually needs to filter through, through the different, through the layers. So it sort of shocks me, and it sort of doesn't, because we've been hearing it as falls prevention researchers for so long. Yeah.
So if you should be able to see that, Kim?
Yeah. Yes. Awesome.
Maybe give me a thumbs up, or let me know when you want to change slides.
I wonder if I can do it myself. Yes, I can. There we go. I can click those arrows. Wonderful.
Okay.
So Thank you, Rachel, for saving me here. But I will just, I'll be quite brief, or try to be, but really give a bit of the lens from the Australian New Zealand Fall Prevention Society, as well as the CRE that Meghan just mentioned on the prevention of falls injury, which is led by Kathy Sherrington, who couldn't be here today, giving an important presentation in New Zealand on falls. And I'm currently the president of the Australian New Zealand Falls Prevention Society. So about 2 years ago, we decided that we wanted, as a society, together with the CRE, do a call for action. And really bring to the attention the issue of falls to the community, to the politicians, to anyone who was willing to listen to us, essentially. And we gathered together, and we did an enormous amount of effort to get to where we are now. You can scan these QR codes. They guide you to 2 separate documents. One is our call to action from the society, where we are presenting the data on Australia, falls in Australia, injury, hospitalizations, deaths, all those numbers. And then you can also see on the right that last year we published a white paper, which was led by the New South Wales Clinical Excellence Commission, and which is a white paper that is actually highlighting the numbers for New South Wales. And while I'm here, that we would actually love it if we could also do something similar for all the states in Australia, where we actually create similar separate numbers for each of the states, and really highlighting the problem of falls and injury-related falls for your state, and the cost that it comes to. Because the more, the louder we are, like, you know, people who shout often get heard. And I think we are all working for a good cause. So I'm just advocating for all of you to be advocates for falls prevention. And it is something that we have learned is very important, is numbers. So numbers are extremely important. They help us to actually put gravitas to the message of falls, and that we can actually do something about it. So what we would typically say is that falls is one of the only public health issues that we actually perfectly know what to do about it. So it does not need to be there. We can prevent it, and we know how to prevent it. But in order to make that happen on a population health scale, we actually need help from governing structures, from politicians, and from departments of health, and so on. So that's where our call for action is. We know what to do, but we need help to coordinate it. So that's where funding also comes in our case. But of course, I don't think it will be a surprise what I will say next. There is no funding. So we just have to do it. But hopefully, the louder we shout, hopefully at one point someone will come up with the idea that this is an important thing to address. So as part of this whole process, this actually has been taken close to 3 years now. And this is the first thing that we did through the CRE, which was, as I mentioned, led by Kathy Sherrington, but we were guided by Bill Bellew, who has a lot of experience in relation to systems mapping, which Nathalia has already spoken about. But we essentially had a group of people, all experts in falls prevention, from various areas, aged care providers to scientists to different areas like stroke, who have some experience. And we came up with this systems map of all the different things that are important for falls prevention. And based on those kind of learnings, we did our launch of our call for action in 2022 at the end of the year, which was a wonderful event and actually attracted quite a bit of media as well. And we had representatives of 2 consumers who actually really made a difference in the presentation, where we had Bob Barnes, who you can see here, highlighting that he was not aware that falls was a thing, and that it only when he got in, like that it happened to a friend of his who didn't come home, that it became that he realized how important it was, and now he is one of our strongest advocates. And one thing that he would say is that falls doesn't discriminate, you know, like it's just, you know, it can happen to anyone. And then we also had Diana Osberg. Some of you might recognize her because she was one of the stars of the TV show Older People's Homes for 4-year-olds. What she said was that having a fall sentences you to social isolation, and that is like I think it's a very powerful statement to make, because it is absolutely something that would be very relevant to older people and might actually stop them from doing the things that they enjoy because of concerns about falling again and the like, and mobility issues that might come through injuries of a fall. We had support by lots of different organizations in this call for action, and we are still continuing to work towards actioning the different things that we have mentioned in there with the organizations. But as part of our work with the Clinical Excellence Commission, and I thought it would be nice to just highlight this here as well, in case any of you is inspired to also do something similar in Western Australia. And I'd be very, very happy to help with this through the society as well, is that we organise a roundtable with various organisations within New South Wales, all the way from New South Wales Ambulance to like heads of departments and other organisations, where we had a roundtable discussion of what they're doing now, what they would like to do, blue sky vision, and what they will do. So we actually tried to lock people down on decisions, but you know, and not that hard, but just within that one meeting that we really came to the point where we actually had actionable items that were feasible. And as a result of this, we came up with this systems map that is specific to New South Wales and is published in the white paper that I sent to link, like the QR code, but you can just type it into Google if you missed it. New South Wales white paper on falls prevention, and you'll find it through the CEC. And here you can see kind of all the different factors that did come up through that roundtable, which are very much overlapping with what is in the paper as well, that Nathalia presented on. So I won't go into too much detail here. But you can see that everyone really recognizes that it all goes from individual factors to actually organizational factors that we need to take into account to make this happen. It's, while we know perfectly what to do for falls prevention, it's not necessarily a simple problem to tackle. As a result of all these things, we have come up with recommendation both on a national level and on a state level for New South Wales. Would be great if we can add more for different states. I'll say it a few times. So you can see the QR codes again here, but really, the one thing that we really need is to have a coordinating body, ideally one that's funded, so that we can bring all those wonderful programs that are available or initiatives that are available out there, and make sure that everyone knows how to find them, but also encourage people to come up with new evidence-based initiatives as well, because we have provided a framework to deliver those programs and help all the older people out there, like regardless of where they live, if they live in a big city or if they live more regionally, more rurally, know how to prevent falls in the future. So we are advocating for a 5-year plan, and we are very much trying to talk to decision makers on making this happen. But so far, nothing solid regarding the funding aspect, but we'll keep working on it. So as I said, we had quite a solid amount of media, and this is actually not including anything in relation to the recent paper, which also added more media in relation to falls prevention. Like just this in itself is very exciting because falls is not a sexy topic, as we all know, and having this in the media in a positive way as how I can prevent falls and what we can do about it is very exciting. Something that I'll also briefly mention, and this is something that Meghan is leading, so Meghan might want to talk to this a bit more afterwards, but we're very much looking into reaching the public, and we would like to do a social media study. So we're planning to do a social media study where we aim to use the different platforms that are out there, all the way from Facebook to Instagram, but also LinkedIn, to reach both organizations as well as professional, like politicians will be on there as well. X is another one that we will target. But many older people now are on Facebook as well, and their family. So we really hope that we can reach a large amount of people. And we plan to evaluate this as well, just to see how successful we were, and yeah, make ourselves accountable in that way, I guess. We've also published a paper as well in Australian. Well, it was an invited editorial on this topic, so it essentially mentions most of what I said in the presentation. So if you'd like to have a read, you can look at it there as well. Thank you. I'll stop there, Rachel. Happy to answer any questions, and for Meghan also to answer questions, of course.
No problem. I guess I will throw this, having a look at the chat now in terms of questions. I think that question that Dr. Rao had about falls indicators has been answered. Thank you, Tony. Does anyone else have any questions for Kim, Meghan, or Nathalia? They're coming through now. Someone wants me to, okay, I will try and reshare the slides.
Oh, Kim, can you put, the last reading? Sorry, I just realised Kim can't do it. Yeah.
Sorry, yeah, I will do it.
I can also, I'll share the link as well in the chat. I'll do that.
Yeah.
That might just be more practical. And I will share the white paper and the national call for action too.
Great, thank you. We don't seem to have any more questions coming through at the moment. I guess very interested, Kim, in the work that the Society is doing and how in Western Australia we can support that in terms of the joint initiatives, and as an agency that delivers mass media campaigns targeting older adults and utilising social media, would be very interested in that work there that you're doing as well.
Right, and I'll just put her on the spot because I just had a look at who's attending. But Christy, Christy Harper, who you might all know,
yes,
got voted in as a new general member of the Society. So, like Christy, I'm sure will advocate for WA, we might be able to make this happen sooner rather than later.
Yeah. I guess in Western Australia we have a state election coming up also in March next year, and as an organisation we're beginning to prepare, I guess, our election priorities that we're asking for. So I think that there's opportunity there for joint advocacy relating to falls prevention. Obviously we would like to see things change at a at a federal level. But I think, yeah, there is that joint opportunity as well. The quick question here: who can join the society?
Well, anyone can join the society. So we typically have members join at the time of conference, but you can also reach out to join the society at any point in time. So you can have a look on the website and email us that you would like to join, and that we will then guide you through the process.
So Suzanne's made a comment that we held, Injury Matters, we hosted a conference at the workshop there, and it was on collaborative falls prevention efforts. And the learning that our presenters had from that was how important the health professionals and others working in falls prevention to understand the roles, each other's roles and collaboration. I guess to support collaboration in that. And I think some of the research that we've done around the importance of collaboration between disciplines like pharmacy and GP, exercise physiologies, OTs and physios as well, and understanding each other's roles to be able to refer effectively.
Yeah, agree. Yeah.
Yeah. A question from Alyssa Burton. Do you think you might get more traction on the policy side if it was more of a national collaboration? Much more work seems to be driven from New South Wales with some others, perhaps from Queensland and Victoria. If researchers were working together across Australia as a whole from different pieces, keen to hear your thoughts on that.
I think we'll all nod to that. Yes.
Yeah.
Correct.
Thanks for the question, and that's exactly what we're trying to do through the society as well. So to have to actually all say the same message. So part of this exercise was actually making sure that we knew what we were saying as well. Like even though we really know everything, like from a scientific point of view, we do need to speak the right language to make sure that we engage the public as well. But yes, absolutely, and that is what we're doing as part of the society, and it's partly also, you know, why we wrote the paper as well, and the opportunity here to make sure that we spread this message and we all say the same thing. It's not rocket science. We know what to do, and there are ways of actually making this happen. And having this same call for action from all the different states will absolutely make a difference to actually get traction on a federal level. One of the reasons why we get traction in New South Wales is because we have the CRE led by Kathy Sherrington in New South Wales. I'm based in New South Wales. We're both based in Sydney. And we are both part of a network that is called the New South Wales Fall Prevention Network that is very active. So we actually have a bit of a voice there, and that it is actually working, which is very promising. So being able to do this in other states would absolutely make a difference. That's where we would like to have white papers everywhere.
What do you think the main barriers are then to that collaboration, Kim?
I think it is like, I'll say it differently. I think an enabler is having that personal connection with someone through either a network or that you actually, or like if you know a politician. We actually had a chat with a guy from in the area of stroke who ended up going to the same cafe of someone who actually was a decision maker and actually chatted to that person in the cafe when getting a coffee. And that in itself was sometimes that is enough to actually get someone's attention. So it's while that is a hard one to kind of hear, because it's not that easy to make that happen. But having that personal connection with a decision maker or with an organization like the Clinical Excellence Commission, through professionally or personally, would actually absolutely be an enabler to make things happen. It's partly up to us to also reach out to those people and yeah, even if we do get knocked back, just keep knocking on the door. You know, the squeaky wheel situation. We are fighting for a good cause. So having those connections is absolutely what make it happen, because we can't do it as scientists. We just don't have the power unless we have a connection with someone who is a decision maker.
I think a really nice example of the power of really strong collaboration at the moment is the topic of vaping, where we've seen people from across the fields of public health that have different purposes, and education and nursing all come together and really advocate for change and get on something really quickly. To me, if we in Falls could harness some of that collaborative effort, I think that would go a long way, because, as you said, it's a really important cause.
I think
and I think
right,
no one's arguing against.
No,
I think that's an interesting thing. No one's arguing against us that falls aren't important, but
no.
I think there is some of those unconscious biases where the priority, we say that it's a public health priority, but we don't fund it like the other priorities.
No.
Yeah,
I think
absolutely.
I think you're right, and I think that's the point of, you know, the CRE, and I think that's the point of the society trying to lead this, start taking it away. It's not individual researchers trying to push this forward. It's, you know, what we have as you know, kind of bodies to try to push it forward, rather than individual researchers or research collaborations. It's and I do want to say that for the society has had messaging up on its website to say, if you want to get involved, please tell us, we need your help. And so, you know, as individuals right across the country, we can actually go onto the website and lend our support, and in that way.
Yeah, great.
Yeah.
I think as we have gone over a little over time, I might draw the conversation to a close then. I want to say a big thank you, Nathalia, Kim and Meghan, for taking your time out of your day to share your research with us. And as I said, I think there's lots of opportunity for joint collaboration, and I will definitely be one of those people picking up the phone moving forward to have a further chat. Just while people are on the line, I did want to mention a couple of other events that we have coming up via webinar in the next couple of weeks. We have evidence-based screening and exercise strategies webinar that is targeted towards exercise scientists that we are hosting in collaboration with ESSA. And we are also hosting a foot health, medication and falls amongst older adults webinar that will have guest presentations from Dr. Amy Page and Professor Hilton Menz, and they'll be exploring the link between foot health and falls risk and raising awareness of the link of polypharmacy, foot health and falls, while discussing ways in which health professionals can identify risk earlier when working with older adults. We also have our existing online modules, which are free for everyone, around an introduction to falls prevention, as well as exercise and screening strategies for falls prevention. They're free, self-paced, and a great opportunity to skill yourself and your knowledge around preventing falls. As always, Injury Matters in Western Australia, I know our audience is a bit broader and national and a few international guests today, but we have a variety of resources that are available for you for free to use with your older adult clients or patients. You can access them and print them off online, or you can order them through our website. And I guess in terms of the next steps, those of you that are based in Western Australia, if you're not already part of the Community Falls Network, I would encourage you to join. We meet quarterly and provide people working in the role of preventing falls amongst community dwelling older adults with the space to share and connect and find solutions together for preventing falls. So reach out to Suzanne if you are not already a member. We also have our Connected program, which is an online networking program for professionals working across all the realms of injury prevention. Participants are connected bi-monthly with another member of the group, and it just, I guess the idea of Connected is it takes the hassle out of networking and provides you with the opportunity to connect with others within the realm of injury prevention. And finally, we would really value your feedback today about what you thought about this webinar, and I believe that you will be receiving in the chat a link to the evaluation survey. If not, it will come via email. So could you please take a moment to fill that in? And just finally, thank you again, Nathalia, Kim and Meghan. And I also wanted to say thank you particularly to Apu and Suzanne at Injury Matters, who did the hard work to get this webinar organised. I believe that most members are probably leaving now, but those of you who are part of the Community Falls Network will be staying on for the CFN meeting. So thank you and enjoy your day.
Thank you.
Rachel.
Thank you, Rachel.